invite Dr. Shroff to speak on the IOL exchange in cases of the subluxated IOL. Dr. Shroff, please. Dr. Shroff.
Yeah, hold on. Can you see the screen?
Yeah, sir, visible, sir. Yes.
Okay, fine. Thank you. First of all, thank you, Rajiv, for inviting me to participate in this wonderful course. And before Herbal's leave, let us congratulate him for being a president, vice president for this society.
Yes.
Now, this IOL exchange is required when your IOL, when you already placed it, or you are about to place it and there is some problem. Either the IOL, when you insert it, the heptic breaks, or when the IOL is subluxated or dislocated, and you want to put the same IOL, but I mean, report is the same IOL, either in sulcus or fixed to the sclera. But it is not possible when you have a capsular support is not inadequate, or IOL has no heptics like Zeiss IOLs or triangular heptics, or IOL or heptic breaks when you want to reposit the IOL. So let us see the very heptic breaks during the insertion. The IOL needs to be explanted, and you put a new IOL.
वो माइक्रोवेव में गरम कर देगा, कर लेना तू.
You can see here the IOL has been already put in, and I have noticed that here I wanted to deposit it in the bag, but there I have seen, I noticed that the heptic has already broken on this side. And now this lens needs to be explanted. Now, what we do, normally we extend the incision and explant it. But what I do, to the same size incision, I hold the heptic, take it out first, and then cut the lens, not in completely half, but then try to cut it. Now try to pull it out. Here, what I made a mistake, that I was trying to put it out because the hulls are not properly made. And you will see that even this heptic is about to break. You can see that it is also broken now. So there is a lens without heptics, and you can see the cut was very small. So I'm holding it, the intravitreal forceps here, and then I'm going to the Caesar. I mean, they put it into the Caesar and making a real big cut into the lens. Now these lens, once I hold it with the forceps from the main wound, see, you can see that to the same size, you can gradually explant like this, rotate it a little bit, and then this take the second portion out. So the lens is explanted to the same size of the wound. The wound was not needed to be enlarged. This is removed, and you can put the new IOL. Now, there is a lens which has been dislocated. The heptics are not proper. If you want to put it into the real good available support, but still you cannot. So this lens is to be taken out, explanted, and the only solution is you must put on the new IOL, which has to be fixed to the sclera. Now there are different various methods, and of late very good methods have come up, like glued IOL or the Yomeni technique, and a lot of modifications. But what we do here, see, we have to, I have taken this lens out into the anterior chamber. It is a triangular heptic. It has been brought out because the capsular bag was also dislocated. You can see that these are triangular heptic. Now it is difficult to fix the same lens to the sclera, so you have to take it out. Now this is my favorite technique of suturing the lens to the sclera, which I have been practicing more than 25 years now. And the sutures, the partial scleral wound is fashioned here on either side, exactly equidistant from the limbus, and then both the sutures at a little distance, they are brought out. So this is the only part, this is intraocular. And once the sutures are taken out, they are cut properly, and then they are fashioned to the eyelet. This is usually I used to use 2 eyelets on the heptics, but now they are not available. So I'm using 1 eyelet on either heptics. The suture is fashioned, it is tied so it doesn't sleep, and then it it is tied to the another portion of the suture, because there are two sutures we have fashioned. So then this part is introduced into the chamber, and then the heptic, the trailing heptic is still kept out, and the suture is fashioned through the eyelet. It is fixed, and again it is tied with the other suture, guiding suture, and then the suture, you can see that the lens has gone inside. The you can pull the sutures simultaneously together, and you can center the lens. And once it is centered, see, this is, you have to tie, and the node goes into the depth of this sclera. You can see that. So this is how we do it. And then suppose the same lens or similar lens we want to put it the same way, but then what happens, because it breaks during the manipulation, and it is so frustrating. You can see that I usually, in these cases, when I want to reproduce the same lens, I usually use triangular flap, go through, put a, you can see that here, the scleroderm incision, and then through do the vitrectomy, clear everything, so that the vitreous doesn't remain in the antechamber. The one heptic is brought out, it is fashioned, but there are no eyelets. So, but still you can hold, tie it, and then the sutures are gone through the scleral lips. Similarly, but then at the end, I realized that the lens was so decentered, and during maneuveration, I did the vitrectomy, and then I just wanted to fashion it and centralize it. But then of late, doing all this maneuveration, I realized that the lens has, the heptic has broken here. You can see that. Now the only way left is to expand the lens, and then we have to put the another lens. Same way, the method what I've shown you in the previous video clipping, the two sutures are passed through the sclera, and then they are fashioned in the eyelet, and then the lens is introduced and put it into the behind the iris, and then the sutures are fashioned, the IOL is centered, and they are tight. You will see here that is a different suture here. See, you can see that. You can see that here. This was our earlier, but then this was a different, they have gone through the different site. So this is how the IOL, dropped IOL has been sutured. There are other methods which you can fix it to the sclera, which has been very popular nowadays, like glued IOL or the Yomini technique. This is the video clipping I borrowed from my colleague, and he has done a modified Yomini technique. You can see that about 1.5 millimeter from the limbus. The tunnel is fashioned on either side of the sclera. You can see here. Similarly, on this side, the lens is brought out here. The one heptic is glued here, put inside, and then little vitrectomy is done. This here also, it is entered. You can see that it is brought out here and it is being put here into the tunnel. You can see here. And similarly, this heptic is also fashioned here. It put into the tunnel here, and it is closed. So this is how we do different techniques to fix the IOL or expand the IOL and put a new one. Thank you, Raju.
Thank you, Dr. Shroff, for excellent presentation and dislocated